Hi, my name is Douglas Tremblay. I'm an assistant professor at the Mount Sinai School of Medicine in New York City, and I'll be talking about erythrocytosis, diagnostic and therapeutic considerations. Here are my disclosures. So first, to start with a definition. Erythrocytosis is defined in men as a hemoglobin greater than 16.5 or hematocrit greater than 49%, and in women, a hemoglobin greater than 16 or a hematocrit greater than 48%. It's also called polycythemia vera, and I'll be using these two words interchangeably during the talk. There is relative polycythemia, which is secondary to dehydration, or absolute, which is secondary to true elevation in red blood cell mass. So this is what happens when you spin down whole blood, where you have packed red blood cells, a buffy coat that contains white blood cells and platelets and plasma. And you can imagine if someone is dehydrated and their plasma volume is lower, then it falsely looks like there's an increase in red blood cells. But true absolute erythrocytosis when there's actually an increase in the red cell mass. And this can be secondary to two different processes, either primary erythrocytosis, which is because of an intrinsic bone marrow abnormality, most commonly polycythemia vera, which I will get into in a little bit, or it can be secondary erythrocytosis, which is an abnormality that's extrinsic to the bone marrow, but causing more red blood cells to be produced. So it's important to understand the regulation of red blood cell production or erythropoiesis to figure out how to differentiate these two. So red blood cells are made in the bone marrow and start from the hematopoietic stem cell. And as maturation occurs, it grows into a proerythroblast, eventually a reticulocyte, and then an erythrocyte, a red blood cell. This process in maturation is often dictated by EPO, erythropoietin, especially at these phases. EPO is produced by pericytes within the kidney, and more EPO is produced in response to hypoxia, which is detected in the kidney from the red blood cells. So higher EPO level causes more red blood cell production. So the causes of erythrocytosis can be thought of as secondary causes, and these can be broken down into appropriate increases in erythropoietin in response to hypoxia. So things like cyanotic heart disease, pulmonary disease, obstructive sleep apnea, Pickwickian syndrome, high altitude, or smoking cause an appropriate increase in erythropoietin. But there's also inappropriate increases in erythropoietin. And often this is from an EPO-secreting tumor, such as renal cell carcinoma or uterine carcinoma or HCC, or a renal lesion, or a specific situation which we encounter, which is after a renal transplant, causes an inappropriate increase in EPO. There's also drug-induced polycythemia, such as from testosterone or exogenous EPO that's used often by distance runners or cyclists to artificially increase the red blood cell amount. And then there's congenital polycythemias, such as true-Fox polycythemia, 2,3-BPG deficiency, and methemoglobinemia. I won't spend too much time on these congenital polycythemias. Now, polycythemia vera, as I mentioned, is the most common primary polycythemia polycythemia. And this is a clonal hematologic malignancy and one of the myeloproliferative neoplasms. So the signs and symptoms of polycythemia vera, or PV, include itching, pruritus in about a third of patients, which is classically described as after a shower or aquagenic pruritus, splenomegaly in about a third of patients, and a group of vasomotor symptoms, one of them being erythromelalgia, which is these painful red lesions and skin markings on the palms and the soles of the feet. There's also headaches from vascular congestion, debilitating fatigue, and facial plethora, as well as gouty arthritis and tophi. So this is a picture of a patient in clinic that we have that has these really impressive tophaceous gout that's secondary to a myeloproliferative neoplasm because of cell breakdown and uric acid deposition. Polycythemia vera, in almost all cases, is caused by constitutive activation of the JAK-STAT pathway because of a mutation in JAK2 called JAK2 V617F. This is present in over 95% of patients with polycythemia vera. And what it causes in the normal situation, erythropoietin causes increase in JAK-STAT signaling and activation of genes for growth and proliferation, but then a negative feedback regulation to kind of shut the system down. In polycythemia vera, you have unregulated red blood cell production because of this mutant JAK2, which causes constitutive gain of function JAK2 signaling, which then causes dysregulated gene activation and proliferation of growth of red blood cells. In patients who don't have a JAK2 V617F mutation, there's also another JAK mutation, which we see in exon 12. And that's in most other patients who have polycythemia vera without a JAK2 V617F mutation. So it's important to recognize that polycythemia vera exists along a spectrum of different myeloproliferative neoplasms, where initially there's a clonal hematopoiesis and the acquisition of a JAK2 mutation that can occur very early in life, even in utero in some cases. This eventually evolves into a proliferative phase of the disease, polycythemia vera, or a related condition, essential thrombocythemia, that's characterized by high platelet counts. And both of these conditions cause vascular events and thrombosis. Eventually, there's transformation of this disease to myelofibrosis, which is characterized by worsening symptoms, cytopenias, extramedullary hematopoiesis, including very large spleen, splenomegaly, and other organomegaly. And eventually, in some patients, this can transform into a particularly aggressive form of acute leukemia. So the diagnostic criteria of polycythemia vera are broken down into major and minor criteria. For the major criteria, erythrocytosis is needed, and in men, that's defined as a hemoglobin greater than 16.5 or hematocrit greater than 49%, and in women, it's defined as a hemoglobin greater than 16 or hematocrit greater than 48%. Or if these aren't present, you can also have an increased red cell mass, which is a specialized nuclear medicine test that is able to tag red blood cells and measure the mass. And above 25% above the predictive value is also diagnostic of erythrocytosis. You also need bone marrow biopsy findings consistent with polycythemia vera, and these include hypercellularity, trilineage proliferation with pleomorphic megakaryocytes, and also a JAK2 V617F or exon 12 mutation. And a minor criterion is a subnormal EPO level. Diagnosis of polycythemia vera requires 3 major criteria, or the first two major criterion and the minor criteria. Of note, you may not need to, by WHO criteria, a bone marrow biopsy may not be required if there's extreme erythrocytosis, such as a hemoglobin greater than 18.5 or hematocrit greater than 55.5 in men, or a hemoglobin greater than 16.5 or hematocrit greater than 49.5% in women. So you may be able to avoid a bone marrow biopsy in these patients. So here's where I'm going to lay out how we think about the diagnostic evaluation of erythrocytosis. So first thing to understand is that it really should be persistent, and that a elevated red blood cell hemoglobin or a hematocrit really should be prompt a repeat value over time to make sure that it's persistent. The first thing we do is check an EPO level and a JAK2 V617F. If the JAK2 comes back positive, then you've made a diagnosis of polycythemia vera, as long as the other diagnostic criteria are fulfilled. If they're JAK2 V617F negative, then if there's a low EPO level, then you consider JAK2 exon 12 testing, which if positive would also diagnose polycythemia vera. But if the low EPO is accompanied by a JAK2 exon 12 negative, then a congenital erythrocytosis evaluation in the appropriate clinical setting should be considered. Patients who have normal or high erythropoietin levels, if this is lifelong, again, a congenital erythrocytosis evaluation should be pursued. But if it's acquired, so a erythrocytosis that's JAK2 V617 negative with a normal or high EPO level that's acquired, should really prompt an investigation of secondary causes for erythrocytosis. Just a word about bone marrow biopsy. As mentioned previously, a bone marrow biopsy can be avoided in patients with extreme erythrocytosis and a documented JAK2 and a subnormal EPO level. However, bone marrow fibrosis at baseline with polycythemia vera is predictive of development of post-polycythemia vera myelofibrosis. And this is shown in a study of about 500 patients with polycythemia vera who have bone marrow biopsies at baseline. And as you can see, patients who had bone marrow fibrosis at baseline have a shorter time to development of post-polycythemia myelofibrosis, so shorter time for progression of their disease. There's also a strong relationship between lymphoproliferative disorders and myeloproliferative neoplasms, and a bone marrow biopsy allows for a baseline assessment. So in our clinical practice, in patients who are diagnosed with polycythemia vera, even if they meet WHO criteria without a bone marrow biopsy, we often advocate for the bone marrow biopsy to be done at baseline for all of these reasons outlined here. So what are the complications of polycythemia vera? Well, the major one is thrombosis. So the major contributor to both morbidity and mortality in polycythemia vera is thrombosis. And this can be arterial or venous thrombosis. And I will pay a particular attention to splanchnic vein thrombosis, such as hepatic vein thrombosis or Budd-Chiari, portal vein thrombosis, mesenteric vein thrombosis, or splenic vein thrombosis, as that population is highly enriched for patients with myeloproliferative neoplasms and polycythemia vera in particular. The annual incidence of thrombosis is highly dependent on age, as shown in this study that looked at patients who are less than 40, where the annual incidence of thrombosis is about 1.8% per year, while patients who are older than 70, the annual incidence is about 5.1% per year. The other major complication we think about is transformation to myelofibrosis, which occurs in the minority of patients. Only 12 to 21% of patients with PV eventually transform to myelofibrosis, but certain risk factors make that risk of transformation even higher, such as thrombocytopenia or leukocytosis. And we often get asked about survival in patients who have polycythemia vera. And this is a large study that shows that the expected survival is shown in black here, and in green is patients with polycythemia vera, showing that the median survival is about 13.7 years, which is worse than in patients with essential thrombocythemia, but better in patients than with primary myelofibrosis. However, this is just a median, and there's many different risk factors and considerations for each individual patient to really accurately prognosticate. So that brings us to how you risk stratify someone with polycythemia vera. Patients by ELN criteria who are high risk are patients who are older, age greater than 60, or have had a prior thrombosis. And risk stratification is really important. In a minute, I'll get into different therapies because this really dictates therapies. Low-risk patients, in contrast, are younger patients less than or equal to 60 and without a prior history of thrombosis. And this is best demonstrated in this ECLAP study, which looked at a large group of polycythemia vera patients. And as you can see, patients who have no prior thrombosis and are younger really have a lower incidence of having a cardiovascular event over time. This is in contrast to patients who are either older or have had a prior thrombosis, which they have a higher risk of having a cardiovascular event. And patients who have a prior thrombosis and are older have a much higher chance of having a cardiovascular event. I will put a caveat here, though, that risk stratification is very complex, and there's multiple factors that affect treatment decisions. And these include cardiovascular risk factors such as diabetes, hypertension, hyperlipidemia, smoking. And there's also symptomatology too. Some of these symptoms portend worse prognosis. White blood cell count may also be a factor that predicts different prognostic factors, but it is very controversial in our field right now. And patient preferences also can determine what treatment options are available. So the management of polycythemia vera, first of all, is phlebotomy, bloodletting. And this was best shown in an older study that patients who have a higher hematocrit level, as the hematocrit goes up and up and up, the amount of vascular events per 10 years really goes up as well too. So because of these hemostatic changes that happen with higher hematocrits, there's a higher risk of having thrombotic events. So this was really tested in an interventional way in the CytoPV study, which randomized patients with polycythemia vera to either two groups, either a high hematocrit goal, which was phlebotomizing to a goal of either 45 to 50% when their hematocrit was above 50% phlebotomizing, or a low hematocrit goal was a hematocrit goal of 45% then phlebotomizing. And what they really showed here is that there is a significant improvement in the events here, which was a composite endpoint of time until death from cardiovascular cause or major thrombotic events. So less death from cardiovascular cause or thrombotic events whenever you phlebotomize to 45%. So our goal for phlebotomy in all patients with polycythemia vera is 45%. Some people will also phlebotomize females to 42%, although that has not been evaluated in a rigorous way. So the goal, as I mentioned, is to reduce the risk of thrombosis in patients with polycythemia vera. And we think about risk stratification on a spectrum. So all patients should have their cardiovascular risk factors that are modifiable addressed, such as diet, smoking cessation, and cardiovascular optimization. All patients to be treated with aspirin and a baby dose of 81 milligrams daily. And all patients should have therapeutic phlebotomy for a goal hematocrit of less than 45%. Now, if patients have a thrombosis, potentially who are older or develop debilitating symptoms, we start to think about instituting treatment, which we call cytoreductive therapy. And most often, the first line agent we use is hydroxyurea, which is a mild form of chemotherapy that we give around 500 to 1,000 or more milligrams a day to reduce the counts in patients who have these sort of risk factors or features. However, there's also interest in the use of interferon, especially pegylated interferon, particularly in younger patients or women who are pregnant. Patients who fail these different treatments, you can think about doing interferon alpha or ruxolitinib. And so I'll spend one moment on ruxolitinib. It's a JAK1/2 inhibitor. As mentioned previously, these patients have overactivation of the JAK-STAT pathway. So ruxolitinib was designed to tamper down and inhibit that pathway. And the study that looked at it was the response trial, which looked at hydroxyurea intolerant resistance patients. And what they really showed is that there's a significant symptom reduction, significant spleen volume control, and significant hematocrit control in ruxolitinib as compared to best available therapy. And in particular, what's most striking is the symptomatology that you get with the symptomatic benefit you get with ruxolitinib. So these are different symptom scores with patients with polycythemia vera. You see you get significant reductions in these scores with patients with ruxolitinib versus standard therapy. So as a result, we often think about giving ruxolitinib for patients who have significant inadequate symptom control. I'm going to spend a second on management of secondary erythrocytosis. And really the underlying theme is that you treat the underlying cause. So for example, if you have someone who has obstructive sleep apnea, then we think about getting them a CPAP machine. If they have a renal cell carcinoma, then we discuss resection with them. And patients who have post-renal transplant, ACE inhibitors and ARBs are actually really efficacious at bringing down the red blood cell counts. For patients who have idiopathic erythrocytosis, so they don't have polycythemia vera and they don't have an identifiable secondary cause, there's no real clear role for phlebotomy in these patients. So you can consider phlebotomy if it improves symptoms or possibly to a goal of 52%, although this hasn't really been thoroughly evaluated either. And you only consider aspirin for patients with secondary erythrocytosis only if there's another indication. So in summary, erythrocytosis can be either primary from an intrinsic bone marrow overproduction or secondary because of an inappropriate EPO increase. Polycythemia vera is a hematologic malignancy where thrombosis is the major cause of morbidity and mortality. Phlebotomy to keep the hematocrit less than 45% is the mainstay of therapy. In cytoreductive therapy in patients who have a prior thrombosis, or an age greater than 60 is appropriate with some caution. And Ruxolitinib, the JAK1/2 inhibitor, can improve symptoms associated with polycythemia vera after you have failed hydroxyurea. Secondary erythrocytosis is first, what's needed to be done is a thorough evaluation of secondary causes. And the role of phlebotomy is debated, only really used if symptomatic. So with that, I want to thank you for your time. And here's my contact information if you have any further questions.